Sure. Hey, Sarah, thanks for joining. My name's Andy Berg, and I'm a 2012 grad of College of Pharmacy. And I've been on the Genesis board now, I think, since 2018. But really excited to have the opportunity to speak with you today and kind of talk about some alternative paths within the pharmacy practice.
And Nicole.
Hi, my name is Nicole Therian. I'm a pharmacist with the Division for Heart Disease and Stroke Prevention at the CDC. I'm a 2020 uh, grad of the College of Pharmacy and 2019 of the College of Public Health at the University of Iowa. And I've been on Genesis board since I think 2022, I think just last year.
And Elizabeth.
Hi, Sarah. My name is Elizabeth Donahue. I am a pharmacist with Lexicom, and I graduated from the College of Pharmacy in 2010. I've been on the Genesis board since, I believe, 2017.
Elizabeth and Sam.
Hey Sarah, my name's Sam Anderegg. I am a 2011 grad. I've been on the Genesis board for several years now. I don't know how many. I did an admin residency and now I work in technology. Started a company like Andy about 7 years ago now. We're an electronic health record for pharmacists. Nice to meet you.
Okay.
Likewise. And I'm just a fourth year pharmacy student. And full disclosure, I just wanted to hop on and kind of like listen in. I actually have a 2-year-old toddler, and dad just took him to Bouncing Birds gymnastics class. And so I was like, finally, I have some free time. I'm just going to kind of listen in on something. And so sorry that I'm the only student here. So, yeah.
No worries. No worries. So I want to kick us off here. So I'm going to go with the first few slides. I'm going to go off camera just so my computer doesn't get too hot here. But yeah, so just a little agenda for us. We're just going to briefly go over the standard challenges. Really we go over the practice of pharmacy, and then the kind of your current challenges in the practice of pharmacy. Go through some innovative practice models, as well as if we have time, we can talk a little about emerging trends and future directions and things. But since you're our only participant tonight, Sarah, feel free to jump in and ask questions, and we can do this more of a conversation if you'd like. If you have other interests or anything you wanted to dive into. Um, but yeah, so just briefly on the tradition of pharmacy is really historically centered really on the preparation and dispensing of meds. So really the that's kind of the pharmacy 101. And prior to, I should say, I don't know, the modern times, in the last, let's say, 20 years, pharmacists were really responsible for compounding, dispensing, and just doing your accuracy checks. And really straightforward stuff: patient counseling, compounding, dispensing, all the stuff that you learn in our classes in pharmacy school. And primarily, when folks thought about pharmacists, they either thought about community pharmacists or they thought about hospital pharmacists, and that's really it. But the cool thing is that there's a lot of other opportunities out there outside of the traditional dual path that most people think when they think about the practice of pharmacy. And as far as adapting, it's really important for pharmacists and other healthcare professionals, just due to many interconnected reasons. Interconnected reasons. So if you think about patient-centered care, it really is important to be able to bring in all sorts of specialties to really tailor a patient's interventions to who they are. So I'll just bring into another example of this is interdisciplinary collaboration. And so my specialty is in specialty and specifically in like rare disease. And so two examples of this, and these specific instances are spinal muscular atrophy clinics or muscular dystrophy clinics or hemophilia treatment centers. In those practice environments, you have interdisciplinary collaboration between pharmacy with physical therapists, occupational therapists, physical medicine, You'll have dentists. You'll have all sorts of different collaborative practice type work. So when a patient shows up at the clinic, they see the full gamut of providers all in one place. And so trying to go from our old school approach thinking about pharmacy to being a part of a larger and greater care team to help our patients is really, really important. And that's kind of goes to really the adapting to the changing healthcare landscapes. In addition, we've got value-based healthcare coming down the pike for large population health type models. That's one of the things SAM addresses, but we also have value-based care for all sorts of different products, medicines, conditions. You have technology advancement. So think about if you have the Epic app and you have your EHR basically on your phone, telehealth, all sorts of digital health type tools, mobile apps, texting services. There are a whole bunch of different things that really when I was in school 10 years ago, 15 years ago, it wasn't, a lot of these things were just starting to come out, but now it's really fun to see that the landscape change. But really the key is that adapting to new innovation and new practice models is very important to doing right by our patients and practicing at the top of our license. And really the purpose of today's presentation is to talk about really all of the above and how we as pharmacists have a lot of different opportunities outside of the traditional really dual path that most folks think about when they think about the practice of pharmacy. I'm going to open anything else I'm missing before I jump into the kind of the first slide on challenges in pharmacy.
Nope, nothing. I'll just add that this is a huge reason why I chose pharmacy, is because there's so many different options that you can choose, and you don't have to decide in your P1 year or P4 year. I feel like I just kept delaying that decision until I kind of stumbled into what I felt like I was supposed to be doing. So, thanks for that good intro, Andy.
Yeah, and so just real briefly on some more challenges. When you think about our patients, I think one of the biggest thing that we were drilled into us in pharmacy schools, medicine doesn't work for patients to take it. So trying to understand and address why patients are non-compliant, non-adherent. And this is something that affects all patients of all ages, races, socioeconomic status, no matter what, you're going to have non-adherent patients. And adherence is vitally important. Adherence to a medication regimen is vitally important to improve patient outcomes. And this is a massive, and I don't foresee any golden ticket or any sort of quick fix to this. Is something that we as clinicians are going to have to deal with really as when we're practicing. But one of the big things from a challenge perspective is trying to figure out what is the trigger that adherence. Managing chronic disease goes right into that, and that is you have the rising prevalence of chronic diseases, the massive burden of diseases like diabetes, hypertension, cancer, cardiovascular disease, and then you have the long-term medical management of those conditions. And then it's a nice little circle right back to where we were before with addressing the medication adherence. Add in patient empowerment and education, and ensuring they have full education on their disease state, and the importance of adherence, lifestyle modifications, therapy. I'm trying to think anything else that kind of goes in there. Other therapy, I should say, diet, exercise, all sorts of things that kind of go into managing a chronic disease. And then at the same time, managing chronic disease now these days is you're incorporating technology into that. So there's a lot of different tools. You have remote monitoring tools, you have mobile applications, you have text-based solutions, you've got telehealth services, virtual health services, chat with a pharmacist services, chat with provider services. So there's all sorts of ways that folks are trying to crack this nut when it comes to managing chronic disease. And it's a challenge that we've had since the beginning of time, and it's a challenge that we're going to have to address as we move forward in practice. And then finally, the other challenge is making sure that everyone understands the full value of the pharmacist within the collaborative environment within the healthcare teams. This is something that we're gonna talk about a little bit later, but basically understanding historical perspectives and the traditional roles of pharmacists as your dispensers, you only count by 5 versus how we are today, active contributors within rounds, within clinics, within various practice environments, and understanding that pharmacists have a very unique expertise in managing medicines. And at the same time, we're understanding the barriers to integration and advocating for us as a profession. And this is another thing that you hear a lot about now if you're following any of the whether it's ASHP or APHA kind of newsletters or email alerts on provider status for pharmacists. So have pharmacists be able to titrate doses for diabetes medicines or intervene on with statins or hypertension medicines or all the above. But that all kind of goes into a challenge we have as pharmacists is having really society as a whole understand the value that we provide to the healthcare ecosystem. Anything I missed on that? I know we're going to go a little bit deeper on that later, but anything else you want to add on that before I jump into the next slide, Drew?
I guess the one thing I would just add is sort of the United States healthcare system. And I know a lot of aspects here, like, managing chronic disease and things like that are part of that. But just a couple other considerations stemming from our healthcare system would be things like drug shortages, which definitely impacted me when I was in clinical practice, and patients with insurance who are underinsured or patients who have no insurance, and how that impacts budgeting and paying for the resources necessary for pharmacists to be able to practice, and pharmacists having support in their practice and staffing shortages and things like that.
Thank you, Elizabeth. Awesome. So let's just talk about a few of the models that we put together on a few slides here today. First one is definitely a massive growing portion of all healthcare spend, not necessarily pharmacy spend, but all healthcare spend is specialty pharmacy. So really the definition of specialty pharmacy is kind of the old school definition is any medicine that costs more than $1,000 a month. That was like when I started in pharmacy, that was like the number. If it's $1,000 a month, oh, it's a specialty pharmacy medicine. Well, now in my practice and we work with, so we're working with medicines that have a price tag of $3.5 million for gene therapies or cell therapies called CAR T products for malignancies that are running $500,000. But we're talking really, really high cost medicines for orphan, really small disease states, orphan conditions. And within specialty pharmacy, you really tailor the healthcare to meet the unique needs of those specific patients, and help them navigate the payer world. So navigate their health insurance, navigate their follow-ups with their medicines or with their providers to have access to those medicines. Kind of that circles back to that first point with their health insurers, and then ensuring that they have full understanding and education on their condition. And you as a clinician in the specialty pharmacy are capturing important data to understand how well the patient's doing on the regimen, and then tailoring that regimen accordingly with actual specific information on in this case, you usually gathered by the specialty pharmacy prior to the refill on that condition. So you tie it all together, bring it back to the provider, and work on really personalizing that regimen to ensure that patient's going to take it. One follow through the regimen, be adherent, we talked about, but also get the most out of the regimen. Some examples of specialty pharmacy practice modules. I'm going to go back to kind of the tried and true one that I'm really familiar with. Oh, perfect. So Sarah, you worked in the SP there, Sue, too. So I might not need to go too much in depth here. I'll just give a couple more examples for us. But the first one is hemophilia, HTC. There's a hemophilia treatment center there in the UIHC, and you have a specific pharmacy that's within the building that only dispenses hemophilia products. And so in that world, the specialty pharmacy is worrying about things like adherence, how much medicine is left on hand, how many doses have been used for on demand or bleed doses, and at the same time marrying up inventory with what's allowed by the pharmacy benefit manager, the payer, before the product shipped. And then, oh yeah, there's the documentation piece that the pharmacy has to do to ensure that they're fully compliant with all the accrediting bodies to ensure that they're still able to be accredited, and then work with those specific payers. Other examples of specialty practice models. You've got oncology specialty pharmacies. So I'm trying to think, is Onco 360? I believe it is a perfect example of a oncology specialty pharmacy that is tailored for the needs of cancer patients. And these specific practices, this specific pharmacy, or oncology pharmacy specifically, would only dispense cancer medicines and any medicines that's needed for, just say, like all your neutropenias, your at-home self-injectables for any of the adverse events around oncology, as well as your other standard adverse events like nausea and vomiting and all that stuff. But basically, they package it up and work directly with the payers and carve out a little business and carve out a niche to specialize for oncology. So those patients get the absolute top class service for the chemotherapy regimen, side effect monitoring, as well as adherence support. And then finally, there's another good example, which are you have the UIHC one that you're very familiar with. Health systems right now are establishing specialty pharmacy practices within the systems, and they are working to integrate the pharmacy care aspect with the clinical services. So the clinical care. So think of a rheumatology patient. They come, they get they get taken care of at the rheumatology practice, and then they're able to walk down the hall to the SP, the specialty pharmacy within the facility, that same facility, and pick up their 3-month doses of Enbrel or Humira. But those are just a couple of really good examples for specialty practice modules. The cool thing is that there's no niches in this space are really powerful, because you can carve out as a pharmacy practice a really valuable service that the larger, let's say, pharmacy, like PBM owned specialty pharmacies, can't do, because they go so broad. They're so broad with their services. So if you want to focus on immunologics, you want to focus on PCSK9 inhibitors, you want to focus on biosims, you can carve out a niche in this specific area and really drive great value for your, in this case, the end customer, the end user is the patient. So the patient gets great care. They work with pharmacists that are clinically trained and experts in this field, but also the health insurers are really happy because they know they're getting the best in class service. So this is a really high growth part of the practice that the opportunities are endless within this specific niche. Anything to add there, group? I know Sam. Sam's in here, and he actually built a specialty pharmacy, so he might want to add some of this too. Anything there, Sam?
I guess from like an administrative perspective, which is how I was coming into it, during my residency, I basically got trained how to start a specialty pharmacy and all the ins and outs. And so when it went down to Augusta, it was infuriating, but also exciting to realize that there are health systems out there that still don't have retail pharmacy services or specialty pharmacy services for that matter, even though they have all these multidisciplinary specialty clinics. And so from an administrative angle, you can make a huge impact on the health system by just understanding and learning how to start one of those things up. It's a huge revenue driver for the institution. It's great for patients. And just another kind of perspective and angle that you can make an impact in this area.
Yeah, and the cool thing is like if you're in the pharmacy department, you've got access to the EHR, so you can see all of the clinical data. You can see the chart notes, labs, anything you need, so you can make adjustments and tailor the therapies to really be impactful for the patients. And like you said, it's really good for the practice, and it also makes pharmacists look great because you're driving revenue for the organization. That's something we don't learn in pharmacy school is how important it is to be within a large organization is people really love you if you drive revenue. And that's one thing that specialty pharmacy does, because it's a massive growth opportunity. There's so many new orphan products coming out, and the administrators really appreciate that.
Yeah, thank you for sharing that. I did have a question. Is there a substantial difference in revenue that's generated if you kind of file for like 340B versus not having that? Just because I see the amount of, the amount that we're paying, or that I used to see the amount that we would pay, for example, like a Humira pen, and then, turn around and be able to process that through insurance. And you're just like, we just made, $2,000 or $3,000 per pen or something like that.
Yes.
Yeah.
That's a 340B program is a massive driver of revenue for the IDNs. Yes, it is, absolutely.
Yeah. Okay.
And that's
But yeah. Does it
Go ahead.
become like an administrative headache though? I mean,
No.
Worth every penny.
okay.
Yeah, it's definitely, yeah, exactly. If you're in the IDN chair, if you're in the health system chair, it's worth every penny, and you'll hire someone to work on the administrative burden, the compliance piece. There are plenty of happy consultants out there that'll do that for you, and there are a lot of IDNs that are happy to hire them because it's a big revenue driver. Finally, this is my last slide here, and then we'll pass it off to Sam. Managed care. So this is one that I was completely in the dark about. I didn't think about this when I was in practice, but this is who I've learned a lot about it recently, because these folks are my customers now for what I do. And managed care pharmacies really is the specialized area of pharmacy practice that focuses on really marrying up pharmacy, really healthcare outcomes through the effective management of the medicines that their specific patient population have access to, and really the cost. So trying to understand, okay, you have 10 options for rheumatoid arthritis. What's the option that is let's say the generic versus, you can think of it through like generic versus brand. So what's a generic or biosimilar option that has fantastic outcomes that's going to save us money? And then of course that in theory should be driving down premiums. And so for the entire population. So that's really optimizing for good outcomes, while also considering the actual value that those medicines provide to the patients as well as to the organization. This is there's a lot of components to this. If you think about the first one, you think of a PBM. Sarah, are you familiar with PBMs, pharmacy benefit managers? Okay, yeah. So if you're in special pharmacy, you probably know. So you got the PBMs, so they play an outsized role in this, in managing the prescription drug benefits for health plans, and also they also have their own, a lot of times their own specialty pharmacy. So they will drive their own medicines to their own central fill locations, to their own specialty pharmacy locations, and that could be good and bad. There's good and bad with that. Probably not the best for patients, because patients need to have options. But it's just kind of a fact of life. And one of the things the PBMs do is they drive rebates. So they use their volume and purchasing power to drive rebates, which the end payer, their customers, if you're a PBM, are the health plans that are your customers, or the large employer groups that are your customers. And so they work on drug pricing, and they optimize formularies, and they enhance cost containment. They really work to drive cost containment for their customers. And that's really the name of the game for pharmacy benefit management. There are a lot of great things. So like if you just read the news, you're going to hear a lot of bad things about PBMs. But there are a lot of good things about PBMs. There are a lot of fantastic clinical programs and opportunities to really impact patient care for the better within a PBM. But they do get an outsized amount of negative press based on just a couple of their tactics for how the market, it's not necessarily them, but how the market has evolved into thinking about paying for healthcare. And that really has to go with rebating. But PBMs are a big part of managed care. Also, when you think about a health plan, so if your health plans develop a lot of their own strategies in-house, but a lot of them will farm out their strategies to the PBM. So if you're a large health insurer, you may have a staff of 20, 25 pharmacists that focus on specific areas. Someone will focus on rheumatology, immunologics, another will focus on cardiovascular disease, another one's focus on specialty, and another one will focus on medical pharmacy drugs, which are drugs that are paid for by the medical benefit. But there's a lot of opportunity within the health plans to improve patient care and to optimize formularies and get better access to medicines for your patients, and set up preferred, non-preferred, and products, as well as work on utilization management, which is the easiest way to think about utilization management is prior auth. So what sort of prior auth process and it makes sense and it's efficient for the patients. And really, from the innovative perspective, there's a lot of cool stuff going on with innovative and like dynamic formulary adjustments based on real-time utilization data, therapeutic alternatives, new FDA-approved agents, as well as cost-effectiveness considerations. So there's a lot of cool stuff going on with managed care. And then really a couple of new things, I should say one more new thing with the managed care that's really interesting is the advent of value-based care, value-based contracting for really high-cost medicines. So, and really a focused piece of managed care pharmacy now is dealing with the high-cost medicines like gene therapies in the millions of dollars that are paid for under the medical benefit. And so there's a lot of really fun, interesting opportunities within the practice to work collaboratively with payers, with manufacturers, as well as providers, to ensure that everyone has access to medicine, the providers have access to the patients, and the patients get access to the medicine that has the best possible outcomes. Really, really cool stuff, and that's kind of where my practice is focused in that space. But really, really cool aspect, a new evolving aspect of managed care. All right, Sam, you are up.
I'll take it over. I just by those first two topics that Andy kind of introduced, if you can't tell, the healthcare system is incredibly complex. And so I feel like when you get into the other side, like these non-traditional areas, like managed care, like gene therapy and specialty, the whole thing's a game. And you wonder why the United States spends $4 trillion on healthcare every year, and we spend way more per capita than any other country and have worse outcomes. There's a lot of games being played in the background. I think, the fun part for me coming into this is learning how the game is played, and what the loopholes are and how people exploit those. I have a very different opinion about PBMs. The three that control 80% of the market are public companies, often owned by health plans, get a whole bunch of kickbacks on the back end. And if you're paying attention to the news at all that's coming to fruition. Now, that's not to say that there's not good PBMs out there. There are a few. But the three that control 80% of the market are don't have their customers / patients' best intentions in mind. And before we move forward, this is getting into like the clinical side of things and non-traditional today probably, but I'm curious for you, Sarah, knowing you have a background in specialty pharmacy at the U. Curious as a P4, like what you're curious about or looking into for the next stage in your journey.
The next stage of my journey, I'm looking at doing a PGY1, either general or acute care residency, and then moving to kind of more of a clinical position. Possibly moving to actually maybe an AmCare position after that, as a clinical pharmacy specialist, kind of partnered along with the specialty pharmacy at UIHC. That's maybe one of the, either that or VA might do PGY2 psych. So
that's awesome.
One of those. They're very different. I also really did enjoy BMT. We did CAR T, so I understand. I've seen the cost of those products as well. So also interested in oncology. So don't know yet. One of those clinical areas. I'm also a non-traditional student. I used to work for the state of Illinois for Illinois Department of Healthcare and Family Services. So background with CMS, Medicare, Medicaid. Mm-mm. Don't really like dealing with it, but I do understand that the healthcare system is complex. Also, I do have family that still lives in Europe. I will say that yes, and then I also used to live in the Netherlands. I will say yes, we do spend more here, but we have better outcomes in more complex disease states in comparison to Western Europe, and my family is still in Central/Eastern Europe, so don't get sick there. Yeah.
Got it. I will
Yeah.
keep that in mind.
But then we also do have a very different culture here that perpetuates all the chronic disease states that we have at a population level. So
Yeah, you got a good perspective on this. And it's encouraging to hear. By the way, if you lean into psych and get more interested in that, please reach out to me and let me know. I've got a classmate of mine who is a psych specialist in the VA. That'd be awesome to talk to.
in Iowa City, perhaps?
Not in Iowa City. She is actually in Iron Mountain, Michigan, in the Upper Peninsula.
Okay. Nice.
But yeah, she'd be great to talk to if and when you need that connection.
Thank you.
But so when it comes to clinical services, so when I was a student, I love people and I love taking care of people, and I love doing that in a way that's more longitudinal versus acute. And my ideal job, I think, as a P1 going into pharmacy school, because I'm a pharmacist like anybody else, you got a plan, you got an agenda, and you're out there trying to accomplish. And I wanted to be like a primary care pharmacist, right? I wanted to see patients. I wanted to, ideally like own a business where I could dispense prescriptions, but spend most of my time providing care to them. And so one of the first things in pharmacy school, I was just asking professors like, it was Jay Curry, and then Karen Ferris at the time was there. She's now at University of Michigan. But my whole thing was like, okay, so how do pharmacists get paid for services? And the answer is not straightforward. But one of the first things they talked about was MTM. And so if you're involved in student organizations or, follow the national organizations at all, the big, rally cry is around provider status. We're providers, we provide care, we should be paid for that care. And so in the 1990s, when the Medicare Modernization Act was passed, they had this little piece of legislation that was part of that called medication therapy management. And that was supposed to be like the provider status, but it kind of got, cut down into, what it is today. And so what MTM is the government said that we're going to privatize Medicare in certain areas. And if you're a health plan like Cigna, Humana, and you offer Medicare Advantage plans to your patients, you have to have an MTM program. And that MTM program has to be run by, I think they specifically called out pharmacists, but pharmacist or an equivalent provider who is going to review medication lists, provide recommendations to optimize therapy, in not so many words. And so what that did is it created an obligation on the insurance companies to run an MTM program. And around the time that law got passed, a little company in Des Moines, Iowa got started. It's called Outcomes MTM. And the health plans who were reacting to this legislation and trying to figure out what they needed to do, 90% of them pressed the easy button and said, we got a vendor that can do this. They can meet all the requirements. We can check a box. We can pay a fee, and we're good to go. And fast forward about 20 years, and here we are today. MTM is a program in which, community pharmacists can provide care and get paid for that care that they provide to patients. And they get paid about $60 per encounter. And the encounters can take, anywhere from 30 minutes to an hour for an initial. They can pay 10 to 20 bucks a pop for something that's called targeted interventions or tips, I think in the outcomes language or lingo. That's closing a gap in care. And so if a patient has poor adherence, under 80% percentage of days covered, they can talk to the patient, try to work with them to get them on medication synchronization, try to get them on automated refills, and improve adherence, and they'll get paid 20 to 30 bucks if they improve that. So when you're looking at the macro kind of level of this, as a pharmacy, about 20% of the people coming into my pharmacy are going to be Medicare patients. About maybe 15 to 20% of those are going to be eligible for MTM. And so the amount of money as a pharmacist running a practice that I can make on MTM is not great. And if I can't provide that care efficiently, then I'm going to be at best probably breaking even on a service like this. But I will say this is the first and probably the most prominent area in which pharmacists can practice clinically and get paid for that. And it's standard around the country, and there's millions of patients that are eligible for this around the country. It is, there are, few positions out there. You can go to work at a health plan. You can maybe go to work at a community pharmacy and spend about half of your time doing clinical services, and cover about maybe half of your salary, providing this sort of care. But there are issues with how this program is run on a federal level. And we as a profession have been championing this. It's been a good thing. It's often associated with managed care. But my opinion, after being in here for over a decade now, it's not serving the purpose that we actually need. And so there has been other clinical models that have evolved and where pharmacists get involved in. You can go to the next slide, Andy, or whoever's controlling them. So collaborative care models. And this is something that I got introduced to when I was a resident in the health system, and then when I was in Augusta, working at that hospital, implementing specialty, is there are opportunities for a pharmacist to be embedded in a clinic. And so you can practically, probably saw this in specialty, right? So you got a pharmacist on the team, actively collaborating with physicians, with nurses to manage the medication-related issues with the patient across a variety of disease states. There are limitations to this. One being that you can practice as a pharmacist, as a provider within a health system, but oftentimes, depending on the state, depending on your health system and your policies and protocols, I might be limited in what I'm able to do. I might need a collaborative practice agreement to prescribe or deprescribe or change a dose. And there's an administrative burden to getting these things set up. There's an administrative burden to a pharmacist getting paid for the service provided. If they're seeing a patient on the same day as a physician, you can't double bill for that. And so these models come with complications, but health systems, like through the specialty pharmacy model, where you get a ton of money coming in for the medication, are able to backstop the actual salary of the pharmacist and cover that salary within the clinic. I think, was it Elizabeth, were you mentioning collaborative practice agreements in our email exchange earlier? Love for you to comment on that. I'm just scratching the surface on the details related to that.
Yeah, so some of the collaborative practice agreements that I was involved in practice, so without getting too much into my backstory, I practiced in patient clinical pharmacy for about 10 years. And we would develop policies through the hospital's pharmacy and therapeutics committee that would allow pharmacists to do certain things without having to run that order through a physician. And it was definitely baby steps toward collaborative practice agreements, but every time we were able to get a new dosing protocol passed through the policy portion of the P&T committee, people wanted more, and they wanted to see pharmacists practicing, higher toward the top of their license. I was in the neurocritical care unit, and before I left, the director of the unit approached me and wanted me to draft a policy giving me almost just, carte blanche for prescribing in the unit. And if that were to be signed for in a policy, then I essentially would be a provider in the unit, and that would automatically be co-signed by a physician without their review. I know that that's a lot of process details, but my overall summary is that people are really desperate for this, especially as resources are getting taken away or not provided in other steps, and other areas are being stretched so thin. So it is a really good actually time for pharmacists to be advocating for these kinds of services, as people are really looking for that.
Thank you. I would agree. I've kind of witnessed that at UIHC, and then also that's also kind of the appeal of working within the VA system when I'm like looking towards the future. So yeah, but thank you for sharing. And
Yep, couldn't agree more. So for you, Sarah, and for anyone else that ends up watching this, I think a lot of the the press and the things going on in the news cycle, and just the general kind of attitude of retail and community pharmacist strikes and shortages and all this stuff, it puts a doom and gloom over the profession, really. But I think the reality is, like Elizabeth's experience, if you expose practitioners to a pharmacist and what a pharmacist can do, and you give them some latitude in order to practice, people realize pretty quick how valuable we are. And so we just need to create more opportunities to expose ourselves to other providers, and we'll continue to advance the profession and move forward. You can go to the next slide. I'll make this quick. I know I'm taking way too long. So this is what I'm most excited about. Provider status and pharmacists independently practicing, and more importantly, independently getting paid for the services they provide. And so provider status on a national level is always, on the agenda, on the, people talking about presentations. And I think the overall perspective in the profession, or the dominating one, is until Medicare passes a law, we're not providers. That is a lie. That is a lie. Over half the states in the United States have passed provider status laws. Majority of those have gone one step further and actually mandated paying pharmacists for services. So now the challenge becomes is how do pharmacists have a patient health record where they can document their encounters? How do they bill them efficiently? And how do they track those claims all the way to payment? So now I'm getting into more of what I think about on a day-to-day basis. There is opportunity here. And I spend 12 hours a day thinking about this all day long. And really, what I think what we'll see over the next 10 years, if we can really thread this needle and make it happen, is pharmacies around the country. There's 60,000 physical locations of pharmacies around the country, and most of them are in areas where there's no good access to primary care. If we can get those pharmacies paid for services and we can expand, we can bring some revenue in. I think what you'll see is these pharmacies now start offering services that you only really see Walgreens or CVS talking about. Coming in for smoking cessation, for diabetes education. They're already coming in for vaccines. That's kind of like the tip of the iceberg here. And so I think you'll see the expansion of this over time, and a lot of barriers, a lot of challenges to get there. But if I were a pharmacy student right now, I'd be super encouraged and excited about my future. So I will pass it off to whoever's next.
Awesome. That's me. So I'm going to highlight a bit about the work that I do, and I actually work in a topic area that my day-to-day is a lot of what Sam just talked about, but from like a research perspective, applied research, looking at what is happening across the country and understanding some of the like really specific like logistical barriers to things like that. but I'll start and speak more broadly. So in my current role, say that I'm a pharmacist with CDC, but I probably act more day to day as a public health practitioner within the topic area of pharmacy, specifically heart disease. So I just wanted to highlight the role of public health practitioners. To their work helps communities or groups of people stay healthy. They can do many types of work, including research, program design, evaluation, collaboration with partners, and tracking data and trends related to health. They can work in many places, including nonprofit organizations, state and local health departments, and government agencies. And they often specialize in topics like infectious disease or chronic disease. Specifically, I work in a federal government agency and in the topic area of heart disease and also in pharmacy, and in applied research or researcher knowledge translation. At CDC, there are pharmacists who do many different types of work, including epidemiologists and folks who work directly with state and local health departments, as well as different topic areas. Next slide, please. So what I do as a public health pharmacist, I'll start with the sort of jargony description of two of the main responsibilities that I have. First, I lead the strategic focus and coordination of pharmacy-related applied research and evaluation studies. Applied research and evaluation studies is the type of studies that my team conducts. So that's why it's that sort of research. As a federal employee on a team that has other staff types like contractors and fellows, I do have some strategic and administrative responsibilities related to our projects. From these projects, I'm responsible for leading or supporting the development of translation materials to support, in particular, CDC-funded recipients to coordinate, plan, implement, and evaluate their cardiovascular-related pharmacist or pharmacy-based strategies. These translation materials include web pages, guides, toolkits, and presentations. Next slide, please. So away from the jargony, what I actually do as a public health pharmacist day to day, about 30 or 40% of my time is spent collaborating with others, this being folks in CDC as well as outside of CDC. And then day to day, the rest of my role is reading, writing, reviewing, and editing document. This includes a lot of emails, which I may share some of this with the others on the call, as well as presentations, internal reports, and some of those translation products I mentioned, as well as administrative documents like project proposals and project plans. So that's all I had prepared. I want to move on so that we all have time to go through our slides, but I can answer questions at the end if we have time.
Thanks, Nicole. I'll keep mine pretty brief. So I'm going to be talking about medical communications. It might not sound like the most exciting topic. Even as I was writing the title, I was thinking, oh man, this is not really an attention-grabbing headline here. I guess to kind of explain a little bit of my path into medical communications, just because it mirrors so many of my coworkers. And because it piggybacks off of something I think Sam said earlier, that he waited a while to figure out what he wanted to do. And I know when I started pharmacy school, I was set on doing bench research. By the end of pharmacy school, I was definitely going to do a PGY2 in psych. In my PGY1, I switched to critical care and specialized in neuro, and I practiced inpatient for about 10 years. And then I started consulting for Lexicomp. And now I work for Lexicomp full time. So just as a demonstration, I'm sure you've heard this a million times from other people, but career paths can certainly take a really winding road. And that is one of the great things about pharmacy too, is that it's not that once I specialized in neurocritical care, that's pretty much where I am. I can do a lot of different things with it to suit, sort of my evolving interests and where I am with how I want to impact patients. So that is sort of a general intro. But there are some different models in medical communications. There's freelance, which is exactly what it sounds like. You're kind of an independent contractor. You take jobs based on your availability and interest and qualifications. There are 1 to 2 year contracts. I know someone who did this for a particular drug. And so she worked directly with the drug company, and she developed education and training materials specifically for that drug company that then they used internally for sales and drug information specialists and their medical science liaisons. And then there are also permanent positions, which describes my position where I work actually for the publisher of LexiComp, which is Wolters Kluwer. And I am not on a contract, except for just a long-term full-time contract. The education and training I already kind of covered how I got to where I am. A lot of people in medical communications will start out in a clinically specialized area, and that is the requirement for several positions. At Lexi, they, for example, they don't. For the position that I work in now, they only wanted somebody who had practiced clinically, and for at least several years. So that was a requirement for my particular position. Drug information is another really good way to get into medical communications. There are definitely PGY2s in drug information. I know UIC has a great one. And that would certainly put somebody in a prime position to work in medical communications later. And then if you're somebody who decides to look at it as sort of an informal, off the cuff education way, you can look into medical writing certificates. University of Chicago has a medical writing certificate. And once I decided that I wanted to transition into medical communications from clinical practice, I actually went through that medical writing certificate, which I think helped as I, applied for jobs within the medical communications sphere, because it showed that I was, really interested in it and not just trying to leave something else. So you can move on to the next slide, Andy. So my day-to-day looks a lot like Nicole's. I laughed when I read Nicole's because it's, writing and editing. I work in a big team of other editors and we bounce ideas off of each other all day. And more importantly, we edit and review each other's work. Every time I make an edit in the LexiComp database, it goes through at least 7 other people who are checking to make sure that it is accurate because of the sheer volume of people who are looking at Lexi as a resource. So that's also part of my day-to-day is doing QA for other people's work. Some of the skills needed for success in medical communications, you do have to be pretty organized. You have to have good time management. And that leads right into one of the big pros, which is that it's really self-driven. I think part of that, is going to depend on your role. But I decide what projects I prioritize. So I do all the neurology content for LexiComp and I do some for UpToDate as well. And I decide, the subarachnoid hemorrhage guidelines just came out. So I'm going to put a calculator update on the back burner because I don't think it's as urgent. And I'm responsible for deciding what is important to update. I also decide who to pull in from a consultant standpoint and who I want collaborating with me on different projects. So it's really self-driven, which is great. Cons, I would say working from home, working remotely and having a really flexible schedule may not work for everybody if they need a little bit more structure. I really appreciate working from home and having a very open and very flexible schedule. Sarah, I've got a 3 and a 5-year-old, so I definitely, I can relate, and that helps for sure. I just put this in the category of other, just as a note. A lot of times in medical communications, your prospective employer does not want you to have any relationship with industry at all, prior to going into that position. So that was something that I had never done, and that was actually a huge help, for me, was not having any kind of, I was on no speaker bureaus or anything like that. So that is just something to keep in mind, if this is something that interests you. So I know I've talked, I've taken up the time, but yeah, definitely that's the end of my portion.
We did have some time for emerging trends if we wanted to talk about that. I mean, I know we're up against the hour. Kayla, what do you think?
I would say it is really up to Sarah and Christiane.
Full disclosure, I just heard dad and son walk in, so
All right.
yeah, but definitely up to Christine or the other person on. So, but I'm gonna be hopping off soon, and so thank you guys so much for going over
Awesome.
everything.
Thanks for joining, Sarah. Good luck.
Yeah, thank you.